She was 69 years old, walked to her mailbox every morning, tended a garden that her neighbors stopped to photograph, cooked Sunday dinner for 11 people without sitting down once. Her daughter convinced her to get blood work done, just a routine panel, the kind ordered at almost every annual physical in America. The results came back with a number that was slightly outside the normal range. That number set off a chain of events that took 14 months and 4 specialists to resolve. By the end of it, she was on 2 medications she had not needed before the test, managing side effects from those medications, and living with an anxiety about her health that had never existed before she walked into that appointment feeling completely fine. She told me something I have never forgotten. She said, "I didn't know I was sick until they tested me." That sentence is not a coincidence. It is a pattern. And once you understand the mechanism behind it, you will make very different decisions the next time someone hands you a lab order. My name is Dr. Chimo Okoye. I am a physician, and my clinical work centers on how we make medical decisions for adults in the second half of life. What I have seen consistently is that the same lab test carries a completely different risk profile at 67 than it does at 47. And most people sitting in the exam room have never been told that. Today, I'm going to walk you through 5 specific lab tests I would personally reconsider after 65. Not because medicine is wrong, because the numbers change and nobody is doing that math out loud with you. But before the list, one concept, because without it, the 5 tests will just sound like warnings. With it, they will make complete sense. I call it the reference range problem. Here's how it works. The normal ranges printed on your lab results were built from population studies, large groups of people across all ages. But your body at 68 is not the same as the average body in that data set. 3 things shift the math specifically for lab testing after 65. First, biological values change naturally with age. What reads as abnormal on a standard lab printout may simply be your body operating exactly as it should at this stage of life. The flag on the report does not know your age. It just sees a number outside a range. Second, lab results in older adults have a higher rate of what researchers call incidentalomas, findings that are real, measurable, and completely harmless. But once they appear on paper, they do not stay on paper. They generate referrals, and referrals generate procedures. Third, the treatment triggered by an abnormal lab result often carries more risk at 65 than the condition it is treating. The medication that corrects a number on a panel can introduce a completely different set of problems in an older body, problems that did not exist before the prescription was written. That is the reference range problem. Keep it in your mind through everything that follows. Now, the list. We're going to go from 5 down to 1. Stay with me through all of them. Number 2 is the one that will genuinely surprise you because it involves a test that sounds like the most responsible thing you could do for your health. And number 1 is the lab result millions of older adults are receiving every year with almost no discussion of what happens next. If you aren't subscribed yet, subscribe now because this is a very vital piece of information. Let's get into it. Checkup number 5. Routine comprehensive metabolic panel in asymptomatic adults over 65, specifically the automatic treatment of mildly elevated creatinine. Before anyone interprets this the wrong way, I want to be precise. A comprehensive metabolic panel has real value. Tracking kidney function matters. I am not saying stop monitoring. I am saying that for adults over 65 with no symptoms, no history of kidney disease, and no diabetes, a slightly elevated creatinine reading is one of the most mishandled lab results in routine senior care today. Here is why. Creatinine is a waste product your kidneys filter out. As you age, muscle mass naturally decreases. Less muscle means less creatinine is produced. So your kidneys may actually be functioning well while your creatinine drifts upward simply because your body composition has changed.
The lab flag does not know that. It sees a number above the reference range and marks it abnormal. The doctor sees the flag. The referral to nephrology gets written.
Studies published in clinical nephrology journals have found that mild creatinine elevation in adults over 65 is misclassified as early kidney disease in a significant percentage of cases when muscle mass is not accounted for. The cascade from that misclassification is well documented. Referral to a specialist, a follow-up panel, dietary restrictions, medication adjustments, and in some cases, treatments that put real stress on kidneys that were functioning adequately all along. I want to tell you about Dolores. Dolores is 71, a retired jazz pianist from New Orleans, Louisiana. She was sharp, social, and performing at a small venue on weekends. Her metabolic panel flagged a creatinine level that her primary care doctor described as a concern. She was referred to a nephrologist, placed on a low-protein diet, and started on a medication to protect kidney function. Within 4 months, she had lost 9 pounds, her energy had dropped, and she was too fatigued to perform. She came to me after a second opinion revealed her kidney function, when properly adjusted for her age and muscle mass, was within normal range for a woman her age. She had spent nearly a year managing a condition she did not have. She said to me, "I gave up the one thing that kept me going because of a number on a piece of paper." That sentence should be in every conversation that starts with a flagged creatinine. What to ask instead? Request that your doctor calculate your eGFR using an age and body composition adjusted formula, not just the raw creatinine number. Ask specifically, is this elevation new or has it been stable over several years? A stable number in an older adult tells a very different story than a rising one. Checkup number 4. Routine vitamin D testing followed by high-dose supplementation. This one has become so normalized that questioning it feels almost unusual. Vitamin D testing is ordered at nearly every annual physical for older adults. I am not arguing that vitamin D is irrelevant to health. I am saying that for adults over 65, with no symptoms of deficiency and no conditions that impair absorption, the automatic pipeline from test to diagnosis to high-dose supplementation is doing real harm that most patients are never warned about. Here is the mechanism. Vitamin D insufficiency has been defined by a reference range that many researchers now consider too conservative, meaning a large percentage of perfectly healthy older adults will register as deficient using current lab cutoffs. That flag triggers supplementation, often at high doses, and high-dose vitamin D supplementation in older adults has been linked in multiple published trials to an increased risk of falls, not a decreased one, when levels are pushed too high. A 2022 analysis of randomized controlled trial data found that aggressive vitamin D supplementation in older adults did not reduce fracture rates, and in some cohorts was associated with elevated fall frequency due to effects on neuromuscular function. The trial that generated the most attention in this space found that among adults who received high-dose supplementation to rapidly correct a low lab value, fall rates were measurably higher than in the group that received a modest, conservative dose. So the cascade looks like this. Routine test. Low reading based on a contested reference range. High-dose supplement prescribed. Neuromuscular effects that increase fall risk. And an older adult who started with no symptoms is now at greater risk of the very injury they were trying to prevent. I want to tell you about Franklin. Franklin is 74, a retired high school football coach from Baton Rouge, Louisiana. Active, steady on his feet, coaching youth flag football on weekends. His vitamin D came back low at his annual physical. His doctor prescribed a high weekly dose to bring the number up quickly. 6 weeks later, Franklin fell on his front steps. He said his legs felt unreliable in a way he had never experienced before, like they were not responding the way he expected them to. He fractured his wrist catching himself. He told me, "Coach 60 kids for 20 years without going down once. Then I start a vitamin and can't trust my own legs." The supplement meant to protect him contributed to the exact outcome it was supposed to prevent. What to ask instead? If vitamin D is flagged, ask your doctor, is this reading based on symptoms or purely a number? What dose would bring me into range gradually rather than aggressively? And can we retest in 90 days rather than escalating immediately? Checkup number 3. Routine thyroid panel with automatic treatment of subclinical hypothyroidism in adults over 70. This is the one that surprises people most, because a thyroid test sounds straightforward. A simple blood draw, a number, a pill if the number is off, clean and easy. The reality in adults over 70 is far more complicated than that, and the data behind it should be part of every conversation that ends with a thyroid prescription. Here is the issue. TSH, the thyroid stimulating hormone measured in a standard panel, naturally shifts upward as we age. What registers as subclinical hypothyroidism in a 45-year-old may simply be the normal physiological range for a 72-year-old. Multiple large studies, including a landmark analysis published in JAMA Internal Medicine, found that treating subclinical hypothyroidism in adults over 65 produced no measurable improvement in energy, cognitive function, mood, or quality of life compared to placebo. But here's the part that matters even more. Thyroid hormone replacement, when it tips even slightly high, increases the risk of atrial fibrillation and accelerates bone loss in older adults. The margin between corrective and excessive is narrow. And in older adults who often have reduced liver metabolism of medications, that margin is narrower still. The cascade from a routine TSH result in an older adult frequently looks like this. Slightly elevated TSH, levothyroxine prescribed. Dose adjusted upward over several visits to hit a target number. Levels overshoot. Heart rhythm changes. Bone density is affected. And an adult who walked in with no symptoms is now managing cardiovascular and skeletal risk introduced by the treatment itself. Before we get to numbers 2 and 1, I want to ask you something simple. If this video is giving you information you have never heard in a doctor's office, share it with one person before you finish watching. You do not have to explain it. Just pass it along. The person who needs this most is probably not looking for it themselves. Now, back to the list. I want to tell you about Constance. Constance is 73, a retired federal archivist from Baltimore, Maryland. Meticulous, energetic, managing her own finances, her own schedule, and her own garden. Her TSH came back slightly elevated at a routine physical. She had no fatigue, no cold sensitivity, no cognitive changes whatsoever. Her doctor started her on a low dose of levothyroxine. Over the following year, her dose was adjusted twice to bring her number into range. At month 14, she developed palpitations. A cardiologist confirmed new onset atrial fibrillation. She was started on a blood thinner. She called me and said, "I went in for a blood test and came out managing my heart." That sentence stayed with me for a long time. What to ask instead? If your TSH is flagged, but you have no symptoms, ask your doctor. What is the evidence that treating this at my age improves outcomes? Can we retest in 3 to 6 months before starting medication? And what is the risk of mild overtreatment for someone my age specifically? Checkup number 2, routine cancer antigen marker panels, CEA, CA125, AFP, in asymptomatic, average risk adults over 65. Almost nobody is talking about this one in primary care, and that silence is doing significant damage. Cancer marker blood tests, the kind that measure proteins like CEA, CA125, or AFP in the bloodstream, are sometimes offered as part of executive wellness panels or requested by patients who want to be thorough. The appeal is obvious: a blood test that might catch cancer early. What could be more responsible? Here is what that appeal does not account for. These markers are not diagnostic. They are signals. And in older adults, they produce false positive rates that are not disclosed clearly enough at the time of ordering. CEA, for example, can be elevated by inflammation, smoking history, benign gastrointestinal conditions, and the simple physiological changes of aging. CA125 can rise with endometriosis, uterine fibroids, and pelvic inflammation, none of which are cancer. The United States Preventive Services Task Force has explicitly found insufficient evidence to recommend these panels for routine screening in average-risk adults, in part because the harms of follow-up testing consistently outweigh the benefits in asymptomatic populations. The cascade is severe: elevated marker, urgent follow-up imaging, CT scan with contrast, biopsy if imaging is inconclusive. In older adults, contrast CT carries kidney risk. Biopsies carry infection and bleeding risk. And when the workup comes back negative, which it frequently does, the patient has been through weeks of procedural exposure and months of anxiety for a number that was never indicating cancer to begin with. I want to tell you about Winston. Winston is 77, a retired civil engineer from Charlotte, North Carolina. Sharp, self-sufficient, still drawing house plans for friends as a hobby. He requested a comprehensive wellness panel that included cancer markers. His CEA came back elevated. He was told it needed investigation. A CT scan followed, then a colonoscopy, then a biopsy of a lesion that turned out to be benign scar tissue from a surgery he had decades ago. The workup took 4 months. Winston told me, 4 months of thinking I had cancer, 4 months of planning for something that wasn't there. His words were steady when he said it, but the 4 months were not. What to ask instead? If a cancer marker panel is offered or suggested, ask specifically, am I symptomatic in any way that justifies this test? What is the false positive rate for this marker in adults my age? And what is the complete follow-up pathway if the result comes back elevated? Checkup number 1. Routine lipid panel in adults over 80 used to initiate or escalate statin therapy. This is the one that generates the most prescriptions, the one that has been so thoroughly built into routine care that questioning it in this age group feels almost reckless. But the data for adults over 80 specifically tells a story that most patients have never been shown. A lipid panel measures cholesterol, LDL, HDL, triglycerides. In adults between 45 and 70, managing elevated LDL with statin medications has a clear, well-supported benefit in reducing heart attack and stroke risk. That evidence is solid. I am not questioning it. I am talking about initiating statin therapy for the first time in adults over 80 based on a lab number, when there is no prior cardiovascular event and no current cardiac symptoms. Here is why the math changes. Multiple studies, including a substantial analysis published in The Lancet involving adults over 75, found that for primary prevention, meaning people who have never had a heart attack or stroke, the mortality benefit of statin therapy weakens significantly with advancing age. In the oldest cohorts, it becomes statistically negligible. Meanwhile, the side effect profile of statins in older adults is not negligible at all. Muscle breakdown, a condition called rhabdomyolysis in severe cases, occurs at higher rates in older adults. Statin-associated muscle pain affects between 5 and 10% of users, and in an older adult, that pain reduces activity, which worsens cardiovascular health. Statins also interact with a high number of other medications, and adults over 80 are frequently on multiple prescriptions simultaneously. So the cascade from a routine lipid panel in an 82-year-old who has never had a cardiac event looks like this. LDL flagged as elevated, statin initiated, muscle pain develops, activity drops, quality of life decreases. And the cardiovascular benefit that justified the prescription may never have applied to this patient's age group in the first place. I want to tell you about Aurelius. Aurelius is 81, a retired maritime lawyer from Savannah, Georgia. He walked every morning, managed his own affairs, and had never had a heart attack or stroke. At a routine physical, his LDL came back high. His doctor started him on a statin. Within 8 weeks, Aurelius had muscle pain in both thighs, severe enough to stop his morning walks. He stopped the medication after 6 months. He never fully returned to the walking routine that had defined his mornings for 15 years. He said to me, "The pill was supposed to protect my heart. What it actually did was take away the thing that was protecting my heart." That sentence is the clearest description I have ever heard of the exact paradox I want every patient over 80 to understand before they say yes to a first-time statin prescription. What to ask instead? If you are over 80, have never had a cardiovascular event, and a statin is being recommended based solely on your lab numbers, ask your doctor, what does the evidence show for primary prevention in adults my age specifically? What is my actual 10-year cardiovascular risk based on my full profile? And what would a structured increase in physical activity do for this number before we consider medication? That question does not make you a difficult patient. It makes you an informed one. Now the practical piece. Because information without a tool is just worry. And I do not want you leaving this video worried. I want you leaving it prepared. Every time a lab test is ordered at your next appointment, I want you to have 4 questions ready. Not filed away somewhere, actually ready. Question 1. Is this reference range adjusted for my age, or is it a general population average? That single question reframes the entire conversation. It signals that you understand lab values are not one size fits all, and it puts the interpretation where it belongs, on your specific biology, not a population average that may not represent you. Question 2. If this result comes back abnormal, what is the first treatment this clinic typically recommends, and what are its known risks in adults over 65? Do not wait for an abnormal result to ask this. Ask it before the blood is drawn. The answer will tell you everything about whether the test is worth taking. Question 3. Is there a watchful waiting option, and what would we be watching for? For a large number of lab findings in older adults, active monitoring is a clinically sound choice. Asking this question is not avoidance. It is good medicine. Any physician who dismisses it without a clear reason is giving you important information about how they approach shared decision-making. Question 4. If I made one targeted lifestyle change in the next 90 days, which lab value would it move most meaningfully? This question does 2 things. It tells you where your actual leverage is, and it reveals whether your doctor thinks about your health in terms of what you can do or only in terms of what they can prescribe. The answer you want is specific. If it is vague, push for more. A doctor who welcomes those 4 questions is a doctor who is thinking about your health the way it deserves to be thought about. If those questions are met with impatience, or if you are made to feel that asking them is somehow an obstacle to your care, that is worth noting before your next visit. Here is what I want you to do before your next lab draw. Find the last set of blood work results you received. Pull them up on your patient portal or dig out the paper copy. Look at every value that was flagged. Then ask yourself, did anyone explain to me why that flag matters specifically at my age? If the answer is no, bring that result to your next appointment and ask. Not to challenge anyone, just to understand. That single act, reviewing one old result with fresh questions, will change how you move through every medical appointment that follows. You will notice the difference immediately, not because the system will change, but because you will. Now, before next week, I want to give you something you can use before then. Everything we covered today has one thing in common. In every case, the damage began with a number measured at one point in time without the full picture. Here is what most people don't know about blood pressure specifically. It rises twice every day. Once in the morning, the reading your doctor sees, and again between 3 p.m. and 6 p.m. In adults over 60, that second rise is steeper, less predictable, and completely unaddressed by standard care. Aurelius's doctor was treating a morning number, not a full day, not a full biology. I built something for that window. It's called the 4 p.m. Fix, a 21-day afternoon routine, 12 minutes a day, designed specifically for adults over 60 managing blood pressure. It includes a daily tracker, chair-safe exercises, and the exact doctor conversation scripts we talked about today, word for word, ready to hand across a desk. It's $14.99. It's not a supplement. It's the structured daily system for the one window your current care plan has never once addressed. The link is below. If your afternoons feel unpredictable and your numbers still swing despite doing everything right, this was built for you. There is someone in your life right now who is managing a lab result they do not fully understand. Not a family member in general. I mean specifically the person you know who mentions their numbers in conversation, who says their doctor is watching something, who changed their diet because of a result they cannot quite explain. That person needs to see this video before their next appointment. You do not have to say anything about it. Just send it. That is the whole action. If what we covered today changed how you think about the lab results you have been handed over the years, subscribe to this channel. What I am building here is a resource for adults over 65 who want to understand their health clearly, not just comply with it. Next week, I'm covering something that connects directly to everything we discussed today. We are going to talk about what your blood pressure reading actually means after 75, because the targets your doctor is treating to may have been set for a different age group entirely. And the aggressive treatment of blood pressure in the oldest adults is one of the most under-examined risks in routine senior care. Subscribe now so you don't miss it. Take care of yourselves. I will see you next week.